Hello, today we're going to be talking about complex regional pain syndrome, and our group members are Dwani, Abigail, Kayla, and Rachel. Here's our overview for what we're covering today. So, some general information about CRPS. So, it is defined as a syndrome characterized by continuing regional pain that is seemingly disproportionate in time or degree to the usual course of a known trauma or any other lesion. It also has different names. So type 1 is usually called reflex sympathetic dystrophy. And there's also some other names as well that you can read. So CRPS usually affects distal limbs like your leg, foot, hand, or arm. Um, like I briefly mentioned, CRPS is classified in type 1 or type 2. So type 1, there is no major nerve damage, and type 2 is major nerve damage. There is also warm and cold CRPS. So warm, it's generally warmer and red, and cold, it's colder and more blue and purple. The limb is more blue and purple. Um, the incidence and prevalence of CRPS, so it varies by global location, but here in Minnesota, there's about 5 people per 100,000 for type 1 and about 1 person per 100,000 for type 2, and this classifies it as a rare disease. CRPS is most common in females in their mid-30s, and the prognosis of CRPS, 15% of early CRPS, 6 to 8 months, 18 months after the initial injury, fail to recover if they have not received treatment yet. And cold CRPS leads to a more poor recovery. And here are some common injuries preceding CRPS. And then the pictures on the right just give a little bit more information on what people with CRPS experience. So our patient is a 23-year-old female that was diagnosed with CRPS type 1 in early 2016 at 14 years old, after sustaining a right ischium fracture after a skiing accident. And her CRPS moved down to her right medial knee after she started walking again. And she is seeking treatment for sleep disturbances and functional mobility because she is not sleeping very well at night, and her mobility while having a pain flare is decreased. And she has baseline and persistent symptoms that you can read on the left there. And then flare-up symptoms add on to the persistent symptoms when she when there is barometric pressure changes, so like a storm moves in and out of the area, and if there's hormonal changes as well. Some anatomy that is relevant to CRPS. It's the central nervous system, the peripheral nervous system, the skin, muscles, and bones surrounding the affected area. So like in the picture on the left there, you can see that the skin is purple and it looks pretty cold. In this bottom picture, you can see that the skin is kind of waxy and shiny. And on the right here, you can see that the right knee has more hair growth on it. And the muscles can waste away and atrophy, and bones can produce bone spurs and have decreased bone density as well in the affected limb.
So, for the pathophysiology of CRPS, it's very complex and not fully understood. Many professionals believe that it's a multifactorial condition. So, what happens in a normal pain cycle is that you injure yourself, say here on the right in this picture, your hand. Your brain, it sends your nociceptor sends signals to your brain, which triggers this pain cycle, where there can be inflammation and overall just acute pain to like make sure you don't re-injure yourself again. And usually after this, inflammation decreases, and this is where healing begins and the pain subsides. For someone with CRPS, the initial injury triggers an abnormal response, and these nociceptors are highly sensitive. So this is where your pro-inflammatory neuropeptides are released. And then it also has CNS changes as well. So neurons in the spinal cord become more sensitive to pain signals. This is kind of like the turning point of CRPS. So instead of your pain signals or receptors turning off, they keep persisting with that pain. So it keeps sending signals to your brain that you are in pain, which eventually leads to chronic pain. With CRPS, there are also some changes in sensory processing and altered body perception. For your autonomic system, there can be sympathetic nervous system overactivity. So this is what's going to cause the changes in skin color, temperature, sweating, and swelling. There'll be elevated levels of cytokines due to inflammation. And for tissue and bone abnormalities, like Abby was saying, muscle atrophy and changes in connective tissue. So instead of healing and turning this pain off, it just keeps sending signals to the brain, which is where we get this chronic pain cycle. For diagnosis, there's not one standard diagnostic test for CRPS. Usually, clinicians will take patient history and a physical examination. For CRPS, someone needs to have continuing pain disproportionate to any event, so pain lasting longer than when the injury happened. They need to have one symptom in 3 out of 4 of the categories. So sensory, with that perception, vasomotor, is your skin cold? Is it hot? How are your veins and arteries doing? Pseudomotor, are you sweating excessively or unevenly? And motor and trophic, do you have decreased range of motion or changes to your skin? And then at the time of evaluation, you need to have one symptom in 2 or more categories. Autonomic tests can also be really good for CRPS, so this checking sweat production. Imaging and bone scans can also check for muscle atrophy or bone spurs, and nerve conduction studies are really good to determine if it's CRPS1 with nerve damage or without nerve damage or CRPS2 with nerve damage. For medical treatment, someone could take pain relievers such as opioids, antidepressants, and anticonvulsants are also good to reduce nerve pain, and then steroids to reduce inflammation. Different types of therapy is also recommended for CRPS, which will be talked about a little bit more later. But for physical therapy, working on improving range of motion and desensitization to affected area. And then for psychological therapy, with can support the emotional impact of living with CRPS. Occupational therapy treatments will be discussed later. There's also some procedures that can be done, such as intrathecal drug pumps, so putting pain relieving medications directly into spinal fluid, nerve blocks to block signals from sympathetic nervous system, and also other ones as well that are listed here.
And now thinking about the impacts of engaging in occupation for these individuals, there are both physical and psychological effects that play into effect. And this can include the impact and worsening of depression, anxiety, overall function, and quality of life for these individuals. So with this, it can make engaging in daily activities or focusing on simple tasks more challenging or continuously difficult. With this as well, there's also a decrease in motivation and energy levels. So again, this is going to make ADLs and IADLs more difficult or more challenging to participate in. And then, as we talked about briefly before as well, there are motor symptoms associated with complex regional pain syndrome. So this can include weakness, reduced range of motion, tremors, and possibly dystonia. So with these motor symptoms, it can significantly hinder the ability to lift objects or to, again, even complete tasks that require heavy lifting and things like that. And then with these motor symptoms as well, this limits smooth or fluid-like movements. So this can cause, ADLs and IADLs, such as cooking or dressing more specifically, increasingly difficult or even painful for some individuals. And then additionally, it is important to highlight that other areas are also impacted in terms of engaging in occupations. So this includes sleep as a big one. Research shows that individuals with complex regional pain syndrome can have sleep disturbances and sleep disorders. And typically, these individuals get about 5 hours of sleep each night. So, again, having that pain causes sleep disturbances in other areas. And then as well, job maintenance is also impacted. So when you have the decreased motivation, decreased energy levels, it is hard to engage and keep a job because it's hard to focus on the tasks you may have from day to day. So it is very common for individuals to also lose their job after symptoms begin. And then additionally, it kind of goes hand in hand in terms of economic stability. Limitations in daily activity can cause, again, possibly losing a job, which then may affect their economic stability in terms of becoming more economically unstable, or unstable. And then that affects their resources and the money that these individuals may have as well.
So there's three stages of development that CRPS typically follows. The early stage is the acute stage. This lasts about 1 to 3 months and has pretty much of the standard symptoms that were discussed earlier. And then this can impact one's ability to engage in their self-care ADLs and more fine motor skills such as buttoning or tying shoelaces. IADLs can be impacted, work and education can be impacted because there's a reduced tolerance for prolonged sitting as well as typing or writing. And then leisure and social participation are impacted because there's a withdrawal from activities that were previously enjoyed, and now they can become more anxiety-inducing. The intermediate stage is the dystrophic stage. This is where more of the symptoms will progress. It lasts 3 to 6 months. This impacts occupations because there will be just more further limitations in self-care. Adaptive equipment might be required. And then household and community involvement, community management also declines, and they may even stop driving due to the pain. And then a traffic stage is the last stage, the late stage. Here you'll see more of the irreversible changes in skin and muscle. And if CRPS remains untreated, to this point, it can become even difficult to move the affected limb. And so in this stage, there's going to be more severe occupational disruptions. All ADLs, all IADLs might require more support, more modifications. Work and education are often discontinued, and there's often social isolation and mental health concerns as well. Two of the biggest adaptive techniques are energy conservation and activity modification. So energy conservation will help to manage the fatigue, help promotion in participation of ADLs. So some examples here include sitting when grooming or cooking, and then doing activities that require the most amount of energy at a time when you have the most amount of energy. Activity modification includes modifying daily tasks and using more assistive devices that can en help enable engagement in more of the meaningful activities. So some examples can include modifying the dressing routines, using more built-up handles to reduce pain grip, and then also using supportive splints as well. And lastly, some of the interventions here include graded motor imagery and pain management strategies. So graded motor imagery is a three-phase strategy, and it helps to activate both the premotor and primary motor cortices. The first step here is laterality recognition. This is the top picture here on the left. And what happens, it's a process of kind of recognizing one side of the body is distinct from the other side of the body, and it's usually done by showing clients sequences of pictures and then sequences of images of the affected limb, and then they're asked to identify each image as a right limb or a left limb. And the inability to kind of recognize this can be related to having disrupted sensory and motor pathways. The second step is the explicit motor imagery, and this is the process of thinking about moving without actually moving. So this is important because by imagining the movement, there are similar areas in the brain that are involved in the actual movement ones that get activated. So this would be used if the patient states that they are unsure of where their limb is, or even if they experience pain just by thinking about moving their limb. And then the third step is mirror visual feedback. This was kind of introduced earlier. This uses movements of the unaffected body parts to kind of trick the brain into thinking that the affected limb is moving. And this is a picture here on the bottom left. So the affected limb is kind of put behind a mirror, and you look at the unaffected side doing the movements. And because of this, the affected side becomes exercised in the brain. And then another intervention is pain management strategies. So this includes heat therapy, gentle exercises, transcutaneous electrical nerve stimulation. And this is a technique that uses mild electrical currents to kind of stimulate the nerves, reduce pain by blocking pain receptors. And then desensitization, which kind of reduces the sensitivity of the affected areas. So kind of exposing the limb to different sensations, different textures or temperatures can help the brain adjust its response. And then it can also help reduce pain and will aid in improvements in both sleep and functional mobility. And then these are our references. Thank you.